Now we move on to the next presenter. We have Dr. David Nono. Dr. David Nono will be presenting on the topic estimation of standard occlusion rim block height for complete denture fabrication among Ugandan population in Makerere University Dental Hospital, Kampala, Uganda. Clinicians' experiences and perceptions. Over to you, Dr. David.
Thank you. This presentation is strictly about patients who have lost all their teeth, the mother, the father's age. As you will see the age bracket, 28 to 70 plus. We deal with the mainly patients who have lost all their teeth, and we try to make sure they get artificial. We make sure we get for them what they call occlusion blocks. Because they have lost their teeth, we need to find a way of how the size, the height of their previous teeth were. So the world procedure, SOP, dictate that we should use occlusion block, as you see it in the slide. So this is called occlusion blocks. And before you make, you need to see the vertical dimension of the mouth from the lower arch to the upper arch. What is the height? So the process is called bite registration process. And for you to determine that now this is the right height, you are looking at a patient when they are at rest and the patient when they are in occlusion, when they are biting. And you need to get what they call between 2 to 4 millimeter. So these are the artificial, I think some of you maybe this is your first time or you have ever heard about them. What do? We can make them manually, we can make them fixed, and we can use computer, which we call CAD/CAM. Manually, we are calling it conventional complete denture. Then fixed, we are calling it implant supported, this one. And then computerized CAD/CAM. CAD/CAM in full is computer aided design, computer aided manufacturing. So we design and manufacture them. Now, in the whole world, we are seeing patients who have lost it. And what are the causes of this? You find there are caries, periodontal diseases, and then accident. And they are the leading causes of tooth loss or edentulosism. In Africa, people have died. Actually, in Uganda, we have lost MP. This very here, we have lost MP because of the issue related to the teeth. And then in Uganda, the same Uganda, 20 plus age, we have got 1.8%. That is according to the World Health Organization. So you realize that this 1.8, and right now, actually, as I speak, we are counting the number of people in Uganda. It has been 34. Now they are projecting to, we should be around 46, but they are counting, it started on 10 for 10 days. So it's ending on 20th, I think, to see exactly the population we have now. But 10 years ago, we were at 34 million. So look at 1.8% being edentulous. Now, when this patient come to this university, okay, these are the general procedure and the SOP for making these complete dentures. The step is that you need to first get consent form. The patient need to consent by writing down. And then you diagnose, you draw a treatment plan, you take impression, you cast it, you make occlusion rim. Then bite registration, you select the teeth. Now when you're selecting the teeth, now you see my teeth, you look at which color could be better for this patient. And then when you make it in wax, then you do try-in, you process the denture, and then you deliver it to the patient. Now, of all these steps, my interest was on occlusion rim blocks. Why? It is the stage I personally find is very important. When you get the right occlusal rim height, you are going not to waste time in your bite registration. You are not going to waste time in your try-in. So, and I saw students over suffering. You find somebody taking 2 weeks on this bite registration because the rim maybe was not properly made. Now, in Uganda, Ministry of Health policy dictate that we should use internationally accepted height. And these heights are everywhere. When you go to China, India, UK, everywhere, the standard is saying we should use 20 to 22, the height of the upper jaw. The lower, they are saying 18 to 20. Now, the posterior part, the lower, they are saying use only 18. But from my experience in Uganda, we realized we are over trimming. And there was a study that was done in UK and Jordan. They also saw that this height is not working for their patient in their country. I said, no, in Uganda also, let me try to check this height. I don't think if UK is failing to use the same height, Jordan, they are failing, then let me also do my third one in Uganda. And that is why I say, let me do the same height in Uganda. Now, what is the aim? My aim here is to make sure we get the height that will fit the one of Uganda, Ugandan patients. And therefore, when I get it, my aim is now, when this Ministry of Health are trying to review their document on how complete denture patient should be treated when they are making complete denture, they should incorporate my finding. And then there automatically there was a gap. So I want this knowledge gap to be filled. What did I do? I got 240 ORB pairs, the upper and lower, meaning there were 240 patients I saw. And how did I get them? I use sensors, consecutive selection based on sensor. What does sensors mean in sampling? It means that every patient who is coming and this patient is interested in making denture, we sign the consent form, we enroll that patient. And now, what did I do? I had to, when we have patient come, as lost both upper and lower teeth, all of them completely dentular. We do what we call occlusal rim. After occlusal rim, we first measure it, because these rims are coming from different technician or technology. In Uganda, we call them diploma, we call them technician. Degree, we call them technologies. But you find in other area or part of the country, they are all called technicians. Dental technician, dental technology. So when they do these rims, when they bring them to the clinic, our clinic at Makerere, we first measure that height, both upper and lower, before. And then after we have done the bite registration, we also measure again. So that's why here we are saying we measure both before and after bite registration. And who was doing this measurement? We trained this lab technologies. He was a degree holder who is working with us at Makerere. So height of each ORB was measured. And what did we use to measure? We got this set, coffer set, and there's a ruler there and pair of dividers there. So we were using it for measuring. And how do we measure? We go to the deepest part. You can see here how we were measuring. We go to the deepest part, up to up. This is standard by the whole, it's the international standard of measurement. Remember, before study, you have to look for ethical approval. So we got approval from the University, Makerere University School of Health Science, REC, and also in Uganda, for every PhD student or a research done, you must go to the president office. And that president office is called Uganda National Council for Science and Technology. The reference number for approval are all indicated here. And before we went to the university, we had to go get administrative clear. The director had to consent to us, and then all the patients we recruited had to inform written, and it has to be voluntary. Your withdrawal in this study was it could not affect you because it was voluntary kind of participation, and confidentiality and privacy was taken care of very well. Now, this is my result. You realize that most of our patients was ranging between 28 to 78. So, and the majority were 70, 50 plus. So you realize that our complete denture patients are aged. And you see the difference out of 200, you can see male was 88 and female. So you realize female are very sensitive to their aesthetic, beauty, smile. Now, the international height of the 240 international standard, they are saying make sure when you're making this rim in the laboratory, make them to be 22. So ours, you can see before is 21.6, meaning it's very close. And then after is 22, meaning, 19.4, meaning there was a difference of 2.2. So meaning in Uganda, our patient for upper ash, they are less by 2.2 millimeter. These 2.2, they are not easy when you're trimming in the patient's mouth. So I'm trying to make sure when now next time we are making this denture, they have to make it at 19.4. Such that in the bi-registration, we shall be already, we will have eliminated this 2.2. And you can see that the p-value is 0.01. So it is too less. And then when you get to the lower, the same 1.5 is a lot to be trimmed. The before was always together with the international height, 17.9, which is close to 18. This one was 21.6, very close. So meaning Ugandan technologies, we have trained them in a way that they are following the international standard. However, when they bring the work to the clinic, the clinicians are over trimming. They are wasting too much time by reducing it. They have to reduce it by 2.2 for upper, lower 1.5. So this study is going to help a lot the clinician not to over-suffer trimming. Now, what was the implication? What does it mean? There will be improved rehabilitation of a dentures patient. And a lot of time will be saved and resources. Actually, this study, when I presented it to government of Uganda, they had to give me money because they said, instead of university wasting a lot of time and resources on something we can improve, they funded it, but though it was a bit late, the money came late, but it has helped a lot in the making sure this PhD is done. It improved the accuracy of removable complete denture. Now, because I went ahead to do another study, that what we got, does this work for our patient? The result is perfect. Patients are happy, and clinicians are not wasting any more time. I published both papers. Then we are going to review in our next curriculum review. This will be taken care of. We are going to review such that when we are teaching this dental surgery student and dental technology student, we are now looking at the new height. Now, future research. We should be now looking at how to involve this patient in several hospitals, dental hospitals. We did it at Makerere. Now we need to go to other area within the country. So that could be now my postdoc study. I should be looking at that. And then follow up to evaluate patient satisfaction. We did on around 25 patients, and clinicians were very happy. I published it still, but now we want now on a bigger scale. Can I do both in the whole country to see that in Uganda we get the right height? Limitation. This study was done, but I don't know, because being a cross-sectional study, I'm unable to detect the cause of the outcome. Maybe in a longer study, we may detect that what could have caused the outcome to be like that. Then the study was in one dental hospital. Now we cannot generalize it in the whole country. Therefore, post Ministry of Health, and we shall see how it can be reviewed. Then the training institution need also to check that all these are perfect. We are going to do this to ministry and to the training institution in the country. Take home is that provide informed consent is very important in everything. Because I had many objectives, I realized most of the dentists are not consenting to their patient. Then we are going to do follow-up to see that the fabrication steps are okay. Then impression material is very important, and then follow up after complete denture delivery. So that was a take home. Conclusion is that overall, the height of this ORB was significantly different from international standard with our mean age of 54. And these are the height I want now Ugandan to use. 19.4 for upper instead of 22, and anterior posterior 17.4 instead of 20. Then for lower, we should be using 16.4 for anterior instead of 18, and then 16 for posterior instead of 18. And then these are the contributors, the supervisors, and of course, I acknowledge Makerere University for allowing me take this study step ahead. And then, thank you.
Yes, thank you, Dr. David.